Hello, and welcome to the Us versus HPV webinar series taking place from January 22nd through January 28th. My name is Cecilia Schmalbach, and I will serve as the moderator for today's talks. This webinar is hosted by the American Medical Women's Association, Global Initiative Against HPV and Cervical Cancer, and Indiana University to recognize January as Cervical Cancer Awareness Month and to spread awareness about the various diseases caused by HPV beyond cervical cancer, as well as the excellent and effective tools that we currently have to prevent them. The goal of this webinar series is to raise knowledge and to encourage and empower you, the audience, to join us in this campaign. You have a number of ways to access this event: live stream, dial in, and video reply. All webinars are recorded and free. You can find out more information by visiting the GIAHC website or by Googling Us versus HPV. You can also find us on Facebook, Instagram, and our Twitter handle, which is hashtag Us versus HPV. Next slide. I want to take a quick moment to give a sincere thank you to all of our sponsors who have been instrumental in making this webinar series come to fruition. Today's topic is HPV-related non-gynecological diseases and cancers. After I provide a brief background, we will have 3 sessions for the hour, each lasting approximately 15 minutes. We will then open the floor for questions and answers. You can submit your questions at any time, starting from now, through the Q&A icon, which you should find at the bottom of your screen. Selected questions from today's sessions will be answered live during the webinar. All handouts are available through the chat icon, also located at the bottom of your screen. A link to them will also be emailed to you after the webinar. Just in the way of background, as mentioned, my name is Cecilia Schmalbach. I'm a head and neck surgeon and currently serve as the chair of Otolaryngology Head and Neck Surgery at the Lewis Katz School of Medicine, Temple University, and I am the director of the Head and Neck Temple Institute. I have no related financial disclosures. I realize that we have many people that are patients and family members, and you may be joining us for the first time this week, so I just wanted to provide very brief background. We'll be talking about the human papillomavirus, or HPV, which is a small virus, and interestingly enough, we humans are the only known host. It's actually the most commonly sexually transmitted infection, and it's done so through direct contact as opposed to the bloodstream. Now, we tend to divide HPV into 2 different categories. We have our low-risk category, which includes common warts and papillomas, and then high risk, which is associated with the cancers that will be discussed in detail today. As far as statistics, right now there are about 79 million Americans currently infected in the United States. Overall, there are about 14 million infections estimated each year. Although 80% of people during their lifetime will get an infection, only 10% will develop a persistent HPV infection. And I thought it would be fun for you to look at HPV infections, the incidence broken down both by state and gender. This is through the CDC, and essentially the darker the shade of blue, the higher the incidence. So especially for men, you can see where it is most common within the Southeast. Now today, as mentioned, we'll be talking about a host of different cancers. The top blue line is cervical cancer, but as you can see, we're experiencing an increasing incidence of oropharynx cancer, and there are a host of different cancers associated with HPV. And in fact, in the year 2020, it's estimated that HPV-induced oropharynx cancer will surpass cervical cancer. So I think it's only fitting to begin with our first guest speaker, Dr. Cherie-Ann Nathan, who joins us from the Louisiana State University Health Shreveport, where she serves as professor and chair of the Department of Otolaryngology Head and Neck Surgery and director of the Head and Neck Surgical Oncology section for the Feist-Weiller Cancer Center. She brings a wealth of knowledge related to HPV oropharynx cancer, as she currently serves as the vice president of the American Head and Neck Society. She is also on the steering committee for the National HPV Vaccination Roundtable and is an active member on the executive committee for the Head and Neck Cancer Alliance. Dr. Nathan, thank you for sharing your expertise.
Thank you, Dr. Schmalbach, for the introduction and for the opportunity to be part of this exciting week and exciting day. So I'm going to focus on what can we do as providers to help with this epidemic of HPV-associated head and neck cancers. I am not able to advance. Thank you. So oropharynx cancer incidence, as you can see here, is increasing. The black line indicates the overall oropharynx cancer incidence. And when broken down into HPV positive patients and HPV negative cancers, you can see this increase is largely due to the HPV positive oropharynx cancers. On the next graph here, you can see the incidence of cervical cancers, which is on the decline, but oropharynx cancers, the red line is overall, and the brown one shows the increase in incidence is more commonly noted in men. As Dr. Schmalbach said, in 2020, it was believed that cervical cancers would, as a result of the decline, would actually be overtaken by the increase of oropharynx cancers. But unfortunately, this has happened at a higher rate, incidence rate, and we have already overtaken the number of cervical cancers last year. So where do these cancers occur when we say oropharynx? It is seen in the back of the throat, which is the base of tongue, the lingual tonsils reside, as well as the palatine tonsils. So interestingly, these are areas that are hard to examine because of gag reflex and large base of tongue. And so for providers, I think it's important that we always palpate these lesions with our finger to determine if there's firmness or any masses in these areas. So what is the typical presentation? Head and neck cancers was typically seen in older men who were smokers and had a history of alcohol overuse. But this epidemic of HPV head and neck cancers can actually occur even in younger men. And so commonly you will see a 50-year-old man who notices while shaving a lump in his neck. No other symptoms. He feels great, he golfs, runs, has a full-time job, young kids, has never smoked. And so most of us typically don't think this could be a head and neck cancer because he's a non-smoker. Initially, they get treated for an upper respiratory tract infection because that is the most common cause of lymph nodes in the neck. He sees his PCP, they give him 2 rounds of antibiotics, and it doesn't respond. So I think that's important to know that if a neck mass is not responding to antibiotics, it's a good time to refer these patients to an ENT or otolaryngologist because a thorough examination of not only the neck, but the back of the tongue and tonsil with a flexible scope as well needs to be performed. Once that examination is performed, sometimes it will reveal a tumor in the back of the tongue or the tonsil, but often that may not be the case as these primary tumors are small. The next step would be to do a needle aspiration of the neck mass. And these masses are then tested for the HPV virus as well. So any persistent neck mass beyond 2 to 3 weeks in an adult needs evaluation by an ENT. So what is the distinct clinical profile of these tumors? Like we said, it does occur in the palatine and lingual tonsils, which are in the base of tongue. But sometimes we never find the primary, and this is known as unknown primary. These tumors can be typically small, and so they are an earlier T stage. But interestingly, they present with advanced nodal disease, sometimes unilateral neck nodes, and sometimes these nodes can be bilateral and large. So here in this table, we show some of the differences between the HPV negative tumors, which was seen in smokers, and the HPV positive tumors on the left. So poor dental hygiene, not commonly seen in HPV positive tumors. Like we said, not much tobacco use, or often it's less than 10-pack year history of smoking. Alcohol use with decreased intensity and duration. Interestingly, marijuana use has been associated with the HPV positive head and neck cancers, but there's a definite and strong association with lifetime oral sex partners and lifetime vaginal sex partners in the HPV positive cancers compared to the HPV negative tumors. So who's at increased risk for HPV tumors? More commonly in men, risk increases with age. HIV-infected individuals are at an increased risk for these tumors. It's also threefold increased risk of tonsil cancer has been noted in husbands of women with cervical cancer, and individuals with anogenital squamous cell cancer are at a 4 to 6-fold increased risk of tonsillar cancer because of the HPV infection. So demographics, young and healthier, more commonly seen in whites, commonly seen in married men, college educated, and non-smokers and non-drinkers. So for the diagnosis, first the history and examination that we talked about, needle biopsy, and then these tumors are sent for HPV detection. In the past, we did in situ hybridization of either the primary tumor or the neck mass, but because of the expense of in situ hybridization and the fact that it's not universally available, P16 immunohistochemistry is now the accepted surrogate marker for HPV-associated tumors. And once this is all done, we stage the patient. So why is P16 accepted as a surrogate marker? This is one of the key studies that was done by Cherie-Ann through an RTOG study a few years ago. And here on the top panel, you see survival of HPV positive tumors based on in situ hybridization compared to the HPV negative. And you can see both overall survival and progression-free survival on the right is significantly better for the HPV positive patients. So that's the good news. Even though we have an epidemic, these patients with HPV positive tumors do significantly better than the HPV negative patients. On the bottom panel, we have the surrogate marker P16. And again, you see P16 positive patients do better than the P16 negative, both overall survival and progression-free survival. And hence, P16 has been accepted as the surrogate marker. Let's talk a little bit about staging. So on the right, you see the P16 negative oropharynx cancer staging. And here you can see, even if you have one lymph node, which is N1, or a few lymph nodes present, immediately you were upstaged to stage 3 and stage 4. But because patients with P16 or HPV positive tumors have a better overall survival, we have a new staging system for these patients. And you can see that if they have a single node or bilateral nodes and are N1 or N2, no longer are they stage 3 or 4, but these patients have now been downstaged to just stage 1 and stage 2. And this is really exciting, I think, for survivors and for those of you that follow some of these survivorship groups. There's a lot of excitement in the community because from being told they were stage 4 cancers, they are now stage 1 and stage 2 and feel they have a new lease on life. So let's discuss the diagnosis of these patients. I think when you see a patient as a provider, how do we break this news to them? It's very important for us to be evidence-based, have a non-judgmental approach, and educate patients, because many of them have different reactions to being told they have an HPV-associated head and neck cancer. And I think sometimes it's good to give them printed materials so they can digest the information before they come back for the next visit. So how common is this HPV infection, and especially when you compare it to cervical and anal infection? In cervical cancers, HPV infection is noted in 80% or greater in women. Anal cancer, 60%. But for oral HPV infection is only noted in about 7% of the population. However, oral and cervical HPV are not always together, and cervical infection, though, does increase the risk for oral infection. So questions that our patients may ask: can I transmit this infection to others? Should I change my sexual behavior? Oral HPV is not casually transmitted by sharing drinks or a kiss on the cheek. Partners have likely already shared any infections. With new partners, it's important to discuss protection methods, and important to remember to let them know that exposure does not mean cancer. Another common question: can you screen my partner and family for signs of oral HPV? So there's no recommended screening to date, unlike cervical cancer, where the Pap test is well known. And that is because the oropharynx has crypts in the tonsil tongue that is hard to screen. So future screening mechanisms, though, are under study, and it is our hope that there will be one in the near future. The management of these patients was typically chemoradiation, because it is hard to access the base of tongue and tonsil and do wide resections. It requires splitting the mandible. And so chemoradiation became the standard of care. That causes horrible side effects of taste disturbances, dry mouth, swallowing problems with esophageal strictures. So as many of these primary tumors in the HPV era are small and technology has improved, robotic surgery is now being used for many of these early stage oropharynx tumors with smaller primaries and nodal metastasis. And many protocols are underway to de-escalate therapy for some of these HPV-associated tumors in order to decrease the side effects. But what is the most important thing we can do as providers? Vaccination has been shown to effectively prevent anogenital HPV infection, pre-malignancy, and cancer. So I think it's important for us to recommend this vaccination, as immunity is imparted to strains of HPV prior to exposure. It is well known that it does decrease the burden of infection, even at a population level. So the recommendation is routine immunization of 11 to 12-year-old males and females. Catch-up can occur up to 21-year-old for males and 26 for females. But if you are immunosuppressed or gay and bisexual men, it is recommended up to age 26. The most common vaccine now available is the nanovalent that covers HPV 11, 16, 18, 16, and 18 being the ones most commonly associated with the malignancy. 3 doses are recommended over 6 months, but if you get the vaccine before age 15, 2 doses 6 to 12 months apart are adequate. And there is evidence through other studies, like the Costa Rica study, that shows the vaccine is efficacious. Due to the long latent period before cancer development, this cannot be proven in oropharynx cancer, and it is important for us to extrapolate from the cervical studies. Unfortunately, the Center for Disease Control shows that only 65% of girls have received 1 dose, And in boys, 50% of boys have received one dose. So the primary reason is that this vaccine is not recommended by their doctors. So it behooves us to recommend this vaccination to our patients. The National HPV Vaccination has wonderful material, clinical and systems action guides to help all of us in recommending this vaccination. Thank you so much. And here is the website for any further information on HPV-associated head and neck cancers.
Thank you, Dr. Nathan. That was outstanding, and I'm thrilled to see we have great questions coming in. I assure you we'll allot time and we'll answer those all at the end. So thank you, and keep sending them using the bottom icon. It is my privilege now to introduce two very special speakers that are joining us from Garden Ridge, Texas, where they reside, as you can see, with their beautiful daughters. We're in a really unique position where we get to hear firsthand the experience of both a patient and a spouse. Colonel Drichta is retired from the United States Air Force. He was the former chief of undergraduate flying training, and he's joined by his wife Shannon Drichta, who also served in the United States Air Force. She is now a stay-at-home mom and volunteers selflessly at both her school, library, and church. We thank you both for your service and for giving of your time to share your unique experience related to oropharynx HPV-induced squamous cell carcinoma. David, I thought I would let you lead off with just a little bit of a brief background of what your history was from presentation and diagnosis and treatment to give us the lay of the land.
Thank you so much, Dr. Schmalbach. Shannon and I both appreciate the opportunity to speak about this with everybody. I am now retired, and it does say no disclosures on the slide, but I'll tell you that my disclosure is that I was treated by a world-class ENT surgeon, and that is Dr. Schmalbach herself. So thank you for that. At the time, I was 7 years ago, 42 years old. My daughters were 4 and 2 years old. I was active duty Air Force, serving as a squadron commander, a lot of responsibility with 50 instructors and 125 students annually, teaching young fighter pilots how to do the things that we do up in the air. In December, I was feeling really tired, but my job was a pretty stressful job. But I also was starting to get a sore throat. We thought that I had strep throat and was treated, much as Dr. Nathan said, with a course of antibiotics because both my daughters had strep throat. So that made sense at the time. I continued to be more and more hoarse, and then started after Christmas time getting some neck wall lining swelling. So we got the referral over to ENT. Unfortunately, I never made it to that referral and showed up in the ER where Dr. Schmalbach was going to treat me after coughing up blood. It became obvious that there was a mass at the base of my tongue, and was intubated and a trach put in place, and then woke up in the ICU. Scared out of my mind, quite frankly. Again, I was 42 years old, had no idea, and I was a really pretty healthy person. I was an Air Force fighter pilot, so this was quite a shock. The kind of next things that happens are you start wondering about lots of questions about what's going on. You start thinking about percentages, and then when they start throwing around things like stage 4 cancer, you start worried about how long you have to live. I think a seminal moment in my diagnosis was Dr. Schmalbach asking me, do you want to know percentages? He said, you can go look online, but there's going to be a lot of scary stuff out there. And there was, and I didn't. And she said, you really don't care about the percentages. It's either 100% or 0. And so I wrote down on a piece of paper, because I couldn't speak with the trach, that I wanted to be a husband and a father. And that's how we based our treatment. So we treated aggressively with concurrent chemo and radiation. The radiation was a full 70 gray on the left side, where the lymph nodes, 3 lymph nodes were enlarged on my neck, 54 on the right, and then a course of cisplatin broken up into a beginning, middle, and end dose that we had to break up further due to complications because of hearing loss, hyperacusis, and tinnitus, and significant hearing loss. I was very weak. I had lost the ability to swallow. I did have a PEG tube in, fortunately, chemo port, and I had a vigorous oral surgery exam to look at making sure that my jaw and teeth were ready for the radiation and treatment that they were about to get. But I did need a number of IV supplements just to keep me hydrated throughout the treatment. Again, no swallowing. I was fully reliant on the PEG tube for about 2 months to get any nourishment into my body. I did lose 20% of my body weight during that time. It's difficult to describe how painful much of the time was during treatment. We finished the treatment, and it's about June timeframe now, and now hard part of waiting comes into play. Because when you were doing chemo and radiation, it hurt, but at least like you felt like you were doing something about the problem. After that, or sort of during that waiting time, I did get a thyroid storm. Ended up back in the ER and the medical ICU for a period of a week while that cleared up with heart monitoring, and then I kind of lost my thyroid to hypothyroidism. At the end of all of that time, 3 lymph nodes remained large in my neck. Remain large in my neck. The great news was that the primary tumor was essentially gone. So we did. Sorry. Primary tumor was gone, but the lymph nodes were still enlarged, so we opted for a salvage neck dissection. Fortunately, those turned out to be no evidence of cancer in those at that time. I spent a full 14 months with the trach. To this day, I still have a little bit of problem swallowing. I do have some reduced taste. I have a significant dry mouth, and that is difficult. It drives some different eating habits. I enjoy salads and soups a lot more than I do right now, or than I did before. And I'm aggressively doing follow-ups to this day to make sure that we don't have any disease. I will tell you that any PET CT scan from that initial diagnosis to today is a significant emotional event as we wonder what's about to be next.
Yeah. Well,
that was the big picture. Sorry.
Yeah, no, I think obviously you had quite a complicated case, and we all appreciate you sharing on a very personal note what that journey is like. I think for us as surgeons, it's always helpful to hear the patient perspective. I know your wife Shannon's with you, and I just wanted to ask her, what is it that you would want spouses of head and neck cancer patients to know up front? Are there 1 or 2 pearls that you would want to share?
We were talking about it, and everything is completely taken out of your control when you first receive a diagnosis. And one of the things is my mom was also living with us at the time and was stage 4 breast cancer. And so we were dealing with that. And when they say stage 4, it was interesting as we were watching the slides from Dr. Nathan, how they've been able to change the staging. Just because when you hear stage 4, that immediately puts you in a bad state of mind. We came up with a schedule as much as we could, just because David and I were such schedule-oriented people, of like when he needed to take his meds, who was going to be taking him to radiation treatments, who was bringing us meals. Like, we had a huge support structure. I think if I could stress something like that, I mean, we were in the active duty military squadron, and they completely enveloped us and fed us and took care of our young kids, so I could be with David during a lot of his treatments. And then I wrote down, just hospital time is different than normal time. You have to be patient because you're not the only person in the hospital. When you're there, it just seems like you're there for so long. And it's such an odd way that you lose track of time while you're in the hospital. And then always have someone in the room with you, especially with something that we didn't know anybody who had gone through this before. And we've continued that even today with just normal doctor's appointments, taking someone with us, because when you're trying to process information, especially information as scary as this, it is nice having someone else in the room to help you remember what was said and what you need to do.
That's great advice. So extra set of eyes and ears, a support system, and trying to be patient with time. And I think it's great for us as physicians to also recognize, how much patients and families are on pins and needles as we're waiting for results. Were there any specific resources that you found online or through support groups that you'd recommend to others, or was it all through family and friends?
Dr. Schmalbach, I think the biggest resource for information was the medical community. So the hematology oncologist, the radiation oncologist, the head and neck surgeon, the nursing staff, all played a key role in that, down to the people that were giving me the IVs to keep me hydrated. You were absolutely correct that the web can be a scary place when it comes to something like this. And what I found was not helpful in my case was a lot of emotion, because we had plenty of emotion going around in the family already. And about the last thing I needed was emotion. I cannot overemphasize Shannon's comments about having another person in the room when you're getting the information, though, because I know as an Air Force officer, we talk in acronyms all the time. And especially as a fighter pilot, I can have a whole conversation and never had really a true word of English that anybody outside of me understands. Doctors and nurses do exactly the same thing. And it's completely, you got to be ready for it. And so what I did do was I used the web, especially I'm a Googler, but Google Scholar. If you go to Google Scholar, you can get some great fact-based stuff out there, medical journals, medical papers, that will really help you understand some of the concepts if you're a patient. So those are what we really used. And then it was really other people that I had met through the treatment that were going through it that we all shared that information.
Thank you. And just as a reminder to our attendees, at the bottom, there is going to be a box where you'll get some of the resources and you'll receive an email as well. The last question that I have for Colonel Drickta and his wife, Shannon Drickta, obviously you have two beautiful daughters. They were young at the time of diagnosis, 2 and 4. Are you willing to share your thoughts and how you've approached vaccination and your daughters?
Sure can. I have an older daughter who was already in college at the time. She was not vaccinated because we didn't know anything about it at the time, right? The daughters now are 8 and 11 years old, and our 11-year-old just got her first course of vaccination this month as she went for her flu shot and well child. I kind of approach this, and Shannon will have just a word after this, but I'd ask you as a parent or as a provider, does anybody really care how people get the cancer? I would not wish this on my worst enemy. It was truly horrific. As a matter of fact, I've had another patient talk to me and say, if I had known what I was going to have to go through, I probably wouldn't have done it because it was just that bad. So I'd encourage all of us to say, do you really care why? You really just want the person not to have cancer. And I think that's the bottom line. And Shannon just has a little thought in addition to that.
So my thoughts are as like a mom who we have a lot of friends with daughters around the same 11 to 13 age. And I think as doctors, you need to realize that the social media aspect of it and the questions that keep coming up are, when is it safe to give your child an HPV vaccine? Just because, like David said, our 11-year-old is really thin, and people think that you need to wait until they're at a certain weight because it's not based on weight with the vaccination. And so I think as much as you can educate people, just because of what David went through, we will do the vaccination. But that is, I hear that a lot in parental circles.
It's all about education and social media pushback that you guys are trying to overcome.
Yeah, and that's I appreciate you bringing that up because that's really a nidus of the entire week. We want to try and help answer unknown questions and give clarity, and I really appreciate you sharing that. We're lucky that Dr. Nathan sits on the steering committee for the HPV vaccination, and in a moment you're going to hear Dr. Polewski, who's also an expert, and so if you do have any further vaccination questions, please just type them in using that bottom icon. The last point I just want to make, and I appreciate Shannon bringing up age, really the whole goal is to get children vaccinated before age of first sexual encounter. But keep in mind, my opening slide talked about just how ubiquitous HPV is throughout our country. And so there is this social stigma, but it doesn't mean that individuals who get an HPV infection or an associated cancer have done something wrong or more promiscuous per se. So I just want to share that. Thank you again for sharing your story, and we appreciate that you'll be on the line at the end too if there are other patients out there wanting to answer or ask questions, I should say. So
Our pleasure. Thank you.
Thank you.
The last speaker we have before we open up our session to you, the audience, is Dr. Joel Palefsky, who joins us from the University of California, San Francisco, where he is an infectious disease specialist in the Department of Medicine. He has extensive experience in the biology of HPV, serving both as the chair of the AIDS Malignancy Consortium HPV Working Group, as well as the head of their HPV Viral Core Lab. I'm also just ecstatic that he's with us because he received the very prestigious 2018 Lady Gaga Trailblazer Award for this specific type of work. Today, he's going to be sharing his expertise and discussing HPV-associated diseases and cancers, not just a woman's problem.
Thank you very much, Dr. Schmalbach. It's a great pleasure to join everybody this morning. Greetings to everybody from sunny California. And I also want to thank the previous speakers who I thought were wonderful. And I would like to begin my presentation with a disclosure statement. You can see that I have done some work with Merck. I'll be talking a little bit about the vaccine studies that we did with Merck that support the importance of vaccination, particularly in males, in addition to women for whom I think the understanding is a little bit better how important it is to vaccinate them. I've also done some work with a variety of different companies that are looking into better therapeutics for HPV, because this is an area that's very important as well. Preventing HPV through vaccination is the best option, but we have many people who have already acquired HPV, and we would very much like to prevent anybody from suffering any of the consequences, particularly when vaccine is really not an option at that point. So what I would like to do is talk about some of the cancers and consequences of HPV infection that occur in men. I'm not going to be talking about oral cancer. That would be very high on my list ordinarily, but Dr. Nathan already did an excellent job covering that. So I'm going to be talking primarily about some of the other cancers that occur in men, principally penile cancer and anal cancer, and also talk about HPV infection at these sites, which is so important because it really has two main consequences. One is for disease that can occur in the infected individual, and the other, of course, is for potential spread to a sexual partner. So this slide shows the burden of HPV-related cancers and other diseases in men and women globally. On the left is the men on the in blue, and on the right is the women in red. And cervical cancer is far and away the most common and important HPV-related cancer in terms of numbers. But I think many people don't realize that if you take cervical cancer out of the equation, particularly with the rising incidence of oral pharyngeal cancer, that the incidence of HPV-related cancers is about as high, if not higher, in men than it is in women. So I think it is very important for us to focus on the importance of HPV infection in men, both from the point of view of spread of a sexually transmitted pathogen and for the consequences of that infection in terms of potential for cancer. Now this slide shows you that there really are two groups of HPV-related cancers. The ones in red, which are cervical and anal cancer, are those for which HPV is virtually always found. HPV is necessary but insufficient for those cancers, and there really is not thought to be a parallel pathway to developing these. In contrast, if you look at the others in black, they include vaginal cancers, vulvar cancers, penile cancers, and as you heard from Dr. Nathan, oropharyngeal cancers, varying fractions of these are associated with HPV. And we think that there are actually two different ways to get these cancers. The most common, as you can see, is HPV and all of the risk factors that go with those, including sexual risk factors. And the non-HPV ones tend to be, as you heard from Dr. Nathan about oropharyngeal cancer, in older individuals, typically with more traditional cancer risk factors such as smoking and alcohol use. So for those individuals, we don't think that HPV vaccination would specifically prevent those cancers, but still, HPV versions of these cancers are found in more than half of the cases, regardless of which cancer you're talking about. So let's say a few words about penile HPV infection and cancer first. This slide shows you, I think, an important fact, which is that penile cancer is very rare. In the United States, the incidence of cervical cancer, which as you heard is going down, is on the order of 6 to 8 per 100,000. And you can see that when expressed as a per 100,000 figure, the incidence of penile cancer is considerably lower than that. It's also pretty flat as a function of time. And you'll also see that the younger people are less at risk for penile cancer than the older individuals, typically 45 to 74 here in the dotted line here at the top. So penile cancer is rare and typically in older individuals. When people think about penile infection, in this country at least, they're not so much thinking about the risk of penile cancer as much as they are about whether they have penile HPV infection and what it means for their sexual partners. So a question that I often get asked as an STD person is there a diagnostic test for HPV on the penis? Similar to the question that Dr. Nathan was addressing for the oropharynx. The answer is no. You can do swabs for HPV DNA, but these are not FDA approved. It's hard to swab the dry surface like the penis compared with swabbing the cervix. And so there really is no approved test to look for HPV infection on the penis. People also ask, well, can I get an antibody test or some other form of blood test? And the answer there also is no. There really is no clinically useful FDA-approved test to look for prior HPV exposure in the blood. People sometimes then ask me, well, can you look for disease? Can you tell me if I have penile cancer or if I have some precancerous changes? And the answer there too is no, because the examination is somewhat difficult, not standardized, and is not considered standard of care. Some have suggested that we use vinegar on the skin of the penis like we use it in the cervix. We do that, but principally for research only. So the best approach really to reducing both transmission and the cancer is to prevent the infection in the first place. That is through vaccination. And we did a study which showed that the vaccine actually is quite effective to reduce penile HPV infection. This was the seminal study, and it showed that in both heterosexual men and men who have sex with men who were on the 16 to 26 age group, that we saw 90% or more reduction in new penile and anogenital HPV infections. That was with the quadrivalent vaccine, and as you heard, we now have a vaccine that includes the same 4 HPV types plus 5 additional ones. So that will help with almost all of the penile cancers that we see, and also with almost all the anal cancers that we'll talk about in just a minute. What else can you do to reduce the risk of penile cancer? Well, in the past, circumcision has been shown to be a factor that might reduce the risk of penile cancer. Those who were circumcised as very young babies were shown to be about 3-fold less commonly at risk to have penile cancer. Some people are getting circumcised as adults, particularly in Africa, often for HIV prevention, and that was shown, not surprisingly, to be less effective to reduce the risk of penile cancer because in most of those cases, probably penile HPV infection had already been acquired. And also depending on which type of cancer, the HPV positive type or the HPV negative type, not really clear exactly how much benefit there is. I will say that now that we're in the era of HPV vaccination, the additional benefit for neonatal circumcision, at least for that purpose, to reduce the risk of penile cancer, will probably be less important than the vaccine itself. Anal cancer, on the other hand, is a different story from penile cancer. This one is going up fairly dramatically. You can see the risk of anal cancer, particularly in women, has been going up as a function of time when the person was actually born in the birth cohort. It's gone up in both men and women, but more prominently in women in the general population. But interestingly, the risk is not evenly spread throughout the population. Some of the increased risk has to do with changes in sexual behavior that we see since the 1960s. And another major one is the HIV epidemic, because people who are immunocompromised are at increased risk, just like you heard from Dr. Nathan about oropharyngeal cancer. And in fact, this is the group that has the highest risk. Men who have sex with men who are HIV infected have had rates as high as 131 per 100,000. Remember, we said cervical cancer was about 6 to 8 per 100,000. Men who have sex with women, 46 per 100,000, and women, about 30 per 100,000. So if you look at the prevalence of anal HPV infection per se, you see that it is actually remarkably common in some of these high-risk groups. 96% of HIV-infected men who have sex with men, 90% of HIV-infected women, and nearly 60% of men who have sex with women. And very high rates of the cancer precursor, which we call HSIL, 43% in the men, 28% in the women. So in these high-risk groups, it's certainly very common. In other high-risk, non-HIV positive but immunocompromised individuals, such as those with a history of transplant, 47% in one study had anal HPV infection. And in the general population of healthy men who have sex with women, one study showed 12%, so lower, but still there to some degree. Fortunately, the HPV types that are found in almost all cancers is HPV-16, which is included in all of the versions of the vaccines that are currently available. The other piece of great news is that the vaccine works just as well to prevent anal HPV infection as it does penile and cervical HPV infection. This study was a little bit lower than we've seen in some of the other studies. A variety of technical reasons for that showed a 77% reduction, but we still think that it will prevent nearly all new anal infection in addition to cervical infection. So for the care of people who have already acquired HPV, who may be too old for vaccination, we actually do have a screening test, although it is not FDA approved or considered standard of care yet, which is very similar to the methods we use to screen for cervical. We do a cytology, which in the cervix is known as a pap smear, and then do an endoscopy to find the lesions, do biopsies, and then treat them usually through removal with heat or electricity if they have a high-grade lesion. So what I'm telling you now is considered expert opinion. It is not approved by the government or any other official bodies, but we believe that the individuals who fall into these lists, which include women with high-grade cervical or vulvar disease or cancer, as well as all HIV-positive men and women, or those who have a perianal change like a wart or immunocompromised due to non-HIV-related causes, should be considered for screening, at least with an anal cytology. This shows you an individual having a high-resolution anoscopy, and we do exactly the same methods as in the cervix. Choice of treatment depends on where the lesions are, inside or outside, but they're usually pretty well tolerated. So to determine whether this should become standard of care, we do some research using a very large study called the Anchor study, which is still in progress. It's going to include more than 5,000 individuals with anal high-grade precursor lesions to see if we can reduce the risk of cancer in the anus, just like we know it works in the cervix. So to summarize, the HPV-related cancers that we're talking about with the obvious exception of cervix and vulvovaginal disease, do affect both men and women. Universal HPV vaccination is the best long-term method to prevent these cancers, and secondary prevention, particularly for anal cancer, is likely, we think, to be possible, and the ANCHOR study will help us determine whether that is in fact the case. So I will stop there, and thank you very much for inviting me to participate in this incredibly important activity.
Thank you, Dr. Palevsky. That was absolutely outstanding. And thank you to everyone that has been sending in their questions. Now you, the audience, get to be the final speaker for us. What I've tried to do is pull together common themes so that we can address as many questions as possible. A lot of questions came up about the vaccination and the fact that recently the FDA has increased the age up to 45 years, but that some of the other medical specialty societies haven't started to promote that. I was wondering if either Dr. Palevsky or Dr. Nathan can comment on the increased age to 45 and how that's impacting practice right now.
Well, I can take a quick stab at that first. The increase to 45 is actually a change that matches approvals already done in several other parts of the world, including many countries in Europe, and reflects the fact that individuals stay sexually active and at risk for new HPV infections even beyond the age of 26, which is catch-up under the prior guidelines. The vaccine is shown to be safe and effective in people between the ages of 26 and 45. And the Advisory Committee on Immunization Practices has not yet weighed in as to whether or not it's going to be a routine vaccination or recommended or not recommended. Most likely it'll be one of the first two. The decision whether or not to get vaccinated, I think, over the age of 26 is, in my opinion, an individual one that the provider should have with the patient, and may depend on a number of factors, including their ongoing risk of new exposure, and to some degree, although it's difficult to quantitate, the degree of prior exposure that they may have had in the past.
Thank you. Dr. Nathan, do you have anything to add to that?
No, I think nothing more to add. Thank you. Well answered.
Yeah. So a question for Dr. Nathan. Someone had inquired, with the change in the oral pharynx staging system, does that mean that we can change our treatment protocols?
So that is a great and important question, because I think that is our concern. The prognosis of the HPV-associated head and neck cancer patients has been good, but based on this aggressive therapy. So most patients, as they were considered stage 3 and 4, got not radiation alone, but chemo and radiation, or in addition to surgery, got the addition of radiation. And so it's important to remember that the new staging system is really more for prognosis and not to change treatment. That having been said, a number of clinical trials are underway and look very promising. And the results of these trials should be out fairly soon, where we will be able to hopefully de-escalate therapy. Many people are already de-escalating therapy, and I think that's okay as long as we do it in the context of a clinical trial.
Thank you. And for the providers out there, I think that the last comment in the context of clinical trials is really key so that we can adequately treat our patients and come up with meaningful conclusions. I did see a number of questions that were specifically related to cervical cancer and partners in oral pharynx cancer. As you saw in the slides, Dr. Falkery and Gillenwater have done quite a bit of work related to oral pharynx cancer, and I think I can address a lot of the questions by just stating that right now in oral pharynx HPV, we know that the majority of the cases, about 95%, are associated with HPV-16 subtype. And in that sense, we're a lot more fortunate compared to our colleagues in cervical cancer, where there are a host of different HPV subtypes. So the question had to do about, for example, there's an 18-month lag period between infection and clearing, and I believe it was Dr. Nathan made the important point that if you're in the setting of a monogamous relationship and your partner gets cancer, you don't have to change your sexual behavior. And really, Dr. Gillenwater and Falkery have nicely put forward that the philosophy is if you've been together for a while, you're monogamous, you've already exchanged that DNA from the HPV. The other point that I want to make is when they have done prospective trials, usually it's men who are non-smokers that are newly diagnosed oral pharynx cancer, and they swab their partners, they found that the incidence of just HPV infection mirrored that of the actual general population. It wasn't greater because they were with a cancer partner or spouse. When they did find concordance, it actually wasn't the same HPV subtype either. And so though it sounds intuitive, the thought that someone who had cervical cancer would then pass along that same strand or subtype of HPV to their partner with oral pharynx cancer really hasn't been found in the literature. Was there, someone wanted to add a comment?
Cecilia, maybe I could just add that what you're saying was absolutely right, but also true of women who are diagnosed with cervical dysplasia, the precancer, which is far more common than the cervical cancer. So I think that's also important for people to remember.
Absolutely. Thank you for sharing that. And again, a lot of great vaccination questions, and I would love to hear Shannon and David Richter's thoughts. There were some questions related to, when they share about vaccination, they often get pushback from friends or family members that by vaccinating their child, they're going to be promoting sexual promiscuity. And I didn't know if you have any experience in fielding that question as a parent and what worked well.
This is David. Thank you. So I don't know of any teenager that's having sex that's really worried about cancer, quite frankly. And so if I carry that question to its logical conclusion is, do we think that, no kidding, the kid is going to be thinking, because I didn't have the shot, I'm not going to have sex? They're teenagers that, what's going to happen with sexual promiscuity is more about discussing values with your kids and not a shot or not getting a shot. Is that
fantastic? No, it's a tough question. Go ahead.
Sorry, I'd like to make a quick comment here. There's actually a study showing that having the vaccination did not increase sexual promiscuity. Fantastic.
No, so we have the science and then we have the boots on the ground, if you will, parental perspective. So that's fantastic. This question I'm going to put out to probably Dr. Palevsky. There were a lot of questions related to the immune system and the fact that their HPV infections are quite common, yet if you look at the overall incidence of the associated cancer, it's not as common. And people were asking, what do we know about the immune system and the immune system's ability to clear those infections?
That's a great question. Clearly, as you said, most people who get HPV infection don't get cancer. And one of the key reasons for that is the effect of the cell-mediated immune response. One of the arms of the immune system does control HPV infection very successfully in most people. There's actually increasing evidence to suggest that we don't truly get rid of every single virus from our body. There may be little bits of HPV hanging around, which again are usually controlled well. And so it's more in a way like a chronic viral infection, but most people feel no effects of that whatsoever. It's only when somebody might become immune suppressed later in life that viruses that they may have acquired earlier in life could potentially get reactivated. So as long as you retain a pretty normal immune system, your odds of not having any serious consequences are pretty good.
Fantastic, thank you. There were a couple of questions about what we know related to vaccination and the prevention of oral pharynx squamous cell carcinoma. I can tackle that and then we'll pass the torch to Dr. Nathan. I think Dr. Palevsky nicely highlighted what we know with respect to penile and anogenital cancer. For oral pharynx, it's a little bit harder. again, because of the fact that so many carriers are present. So unlike cervical cancer, right now we don't screen for oral pharynx infection of HPV. And part of that is that we also don't know what to do with that yet. So right now we don't have data specifically related to how the vaccine is impacting oral pharynx cancer. Certainly down the road, we hope to have greater insight, but again, because we don't know the overall incidence of oral pharynx infection, it'll make it a little bit harder to answer. The other thing that I want to make sure people know is there was a great talk yesterday related to both vaccination and action. Again, these will be available to you online for free. If you go to the GIAHC, G-I-A-H-C website, or just Google us versus HPV, you'll be able to get access, and that can give you further detail related to vaccination. So we're at our time limit. I just want to thank all of our guest speakers for sharing their expertise, and I especially want to thank the audience. Your questions were phenomenal and really helped to drive a very rich discussion. Please get the word out and have a wonderful day. Thank you.